Thank you, Mr. President. I wish to compliment, of course, Ann Woolley for her and for just simply an outstanding presentation. And I wish to elaborate further on the following. One of the issues that we contend with is the pool of organ donors and the possibility of COVID transmission from an organ through transplantation. And so, Ann, if you would elaborate further, you introduced it just briefly, but perhaps to elaborate now, an assurance regarding the organ donor pool, particularly from deceased donors, that impacts hundreds of thousands of patients worldwide. Would you make a comment on the safety of the organ donation pool that has evolved, that we now are accepting donors, dying donors, that have COVID positivity? Your comments. Thank you, Ann.
Okay, let's first listen to Wanderlei Barnato.
Yes, well, wonderful talks. And my question is a simple one, and I appreciate all the talks. And she gave a very nice explanation. My question is, because of we are treating very well the situation and vaccines and everything, but we know that there's been also an abuse of antibiotics altogether. And that may cause another problem, which is the increase of the resistant bacteria. So my question to Ann is that a real problem that we're going to have to face in the coming near future, the resistant bacteria pandemic? Or this is not an issue at the moment, we should only worry about the virus and not worry about this risk of having a tremendous amount of resistant bacteria coming up. Thank you.
Thank you. Volker Termeulen and then Wolf Singer. Volker, you are muted.
So I have a question to the presentation of patients with organ transplantation and with respect to monoclonal antibody treatment. Is there a possibility that one can induce virus persistence with this type of treatment? Is there any observation known that this can happen or not?
Thank you. Wolf Singer, please.
Since coagulopathy seems to be a major problem, both for the cerebral complications as well as the multi-organ failure, why do the classical anticoagulants not really work in this case? Is there something very special about this virus?
And Michael, there was a question in the chat box also to you. Excellent talk, Michael. How would you envisage the best way of following COVID-19 patients over years to see if there is an increased risk of neurodegenerative disease? A question from Andrew Lees, National Hospital, London. Anne, please, Ann Woolley.
Thank you for those questions. So I think to start with Dr. Delmonico's question about the concern for donor-derived infections and how do we make sure that we can continue to expand the donor pool and not limit it by declining unnecessarily organs from donors who have had or have COVID-19 and do this safely. And I think what we have learned is that though SARS-CoV-2 was new to all of us, obviously 2 years ago, I think the difference is we've learned that we know we can manage donors that have other viral infections. And so now that we've learned so much more from the pathophysiologically about it, as well as viral reservoirs for SARS-CoV-2, that we do know with organs outside of the lung, excluding the lungs, since we do not yet have experience with transplanting lungs from donors that have active SARS-CoV-2, that we can do this in a safe way by making sure with all this new advancements with diagnostics and being able to understand what is the level of virus by getting the cycle threshold, which is in proportion, disproportionate to the amount of virus, to then be able to do this safely in a way, particularly which has already been done for hearts, livers, and kidneys. think the second question then was about the concern for multi-drug resistant organisms in the setting of increasing antibiotic resistance. And yes, unfortunately, this is not something that has gone away. We've had this problem, and it's been only a growing problem prior to COVID-19. And I'd say particularly, at least in the US, in the first 6 months of COVID-19, this only was more of a concern because of the empiric use of broad-spectrum antibiotics. I think fortunately in the US and Europe, that has been much further curtailed, and realizing the fact that we do not need to use broad-spectrum antibiotics to treat initially our patients that have SARS-CoV-2. However, what we have just seen is that this has continued to be an issue with resistance. And we know now out of India and now many other countries, the increasing fungal infections that we're seeing as in patients that have COVID-19. And we are also now seeing some multi-drug resistant bacterial infections as well. And so, yes, this is a continuing problem and a pandemic in and of itself. And then the third question, I think, on monoclonal antibodies and as far as viral resistance. So I guess I would think of it as not so much viral resistance as much as the fact that we know that these monoclonal antibodies bind to different epitopes of the spike protein. And what we've already seen with bamlanivimab and esitivimab is that that was not effective against 3 of the prior variants. And so that's why it was taken off the market and not be recommended to be used. But then it does have efficacy against the Delta variant. And so I think that is the growing concern, that though we know monoclonal antibodies can be so effective, is that with more variants, are we going to then have more resistance or evasion that will not actually work for these subunits?
Thank you. Michael?
Thanks very much. If I can take the second question first. The best way to look for the future risk of degenerative diseases, I think, is going to be difficult, but cohort studies following up the group of people who were infected in that first wave, looking at different infections and which variant they had and following them up over the years, it becomes challenging when everybody has been infected to compare with a good control group. But I think, this is the way it should be done, and developing surrogate markers and others to see if we can see any evidence early and to select those who need more intensive follow-up. And then the question on anticoagulation and what is it about this virus that means anticoagulants don't work? Well, certainly in stroke or thrombus, it appears to be a virus which is a coagulable virus. In the acute phases cause disseminated clotting, but also in people in the long COVID clinics, we do still pick up people who've had thromboembolism and pulmonary emboli, and even on a more of a research basis, microthrombotic events or microvascular changes. So it may not be that anticoagulants don't work completely, but that some stronger regimen is needed. And this is where we need, again, randomized trials. This has been more challenging given the heterogeneity, the inability to randomize large number of people to different anticoagulants. But I may ask my colleague to speak now or later, Laura Benjamin, because she's a stroke specialist and working on thrombosis. So if the chair would like to ask her to answer that now or in the discussion.
Yeah, please, Laura, please take the floor.
Yeah, thank you, Michael. I think, can you hear me?
Yes.
Yeah, excellent. I think it's a really important question because SARS-CoV-2 is clearly a coagulopathy-driven virus. And as Michael said, I think there is a spectrum in the group of heterogeneous. Dr. Collins eloquently indicated that our trials are showing that it's effective in the earlier phase, but not in the latter phase where DIC, which is disseminated intravascular thrombosis, is probably ensuing. So we need the trials, we need the collaborative trials to show this definitively. I think some are emerging. I think generally antithrombosis treatment will probably be effective, but selecting the right group. The caveat is thrombosis related to venous thrombosis, as we see related to vaccination. The mechanism is probably immune mediated and very similar to heparin-induced thrombocytopenia. The general recommendation is not to give that because it may exacerbate the process. But generally, as in my experience with stroke, we do have to selectively pick them, but generally have to give them if they have an ischemic stroke with multiple thromboses, which we know could potentially be fatal. And we have given them in a case-by-case basis. Thank you.
Thank you. Michael, were you through? Michael?
Sorry, I
Then-
can't.
Were you finished with your responses?
Yes, I'm finished.
Thank you. Jose Onocek, briefly.
Okay. I was curious about the comments, particularly and comment about the monoclonal antibodies. And I'm very confused what people are saying. If someone is diagnosed with a positive COVID, should they take the infusion of antibodies right at there, or should they wait? They say should do early on the disease, when that should be taken. What's the, based on your response that you're trying to say about the effect of it, do you want to comment on it?
Okay. Volker, is this an old hand or a new hand, which you have up?
Well, this is an old hand, actually.
Okay. Colleagues, let me add one question. So Anne, please respond in a moment to Jose's question. My question is to all 6 speakers, if they could comment on how to deal with vaccination or non-vaccination of young children. We know, I'm talking about under 5. We know they bring home from kindergartens, if there is a kindergarten, or from outside, the virus. What's the concept for young children? And what are the consequences of COVID in young children? We have some pediatrics experts here on the panel. So anyone who feels equipped to comment on that. But before we do that, Anne, please take the floor and respond to the earlier question.
Sure. So if the question is when in the timing, or is it, I think it's twofold. When in the course of the disease, from exposure to disease, is monoclonal antibodies most effective? But it's also, I think, important to think about it as far as who, in which individuals is this most effective. And so when we think about this in simplistic terms, as far as the fact that this is really to help to boost the immune system, if you will, by giving the monoclonal antibody rather than waiting for your body to then develop the antibodies to SARS-CoV-2, that then makes sense as to why the earlier on from when you've been exposed to it, even pre-exposure, why it could be helpful, and why we know it's helpful for those early on in their disease course. And that's why the studies have shown that it should be given within the first 10 days from symptom onset, or if it's exposure, that you've had a high risk, clear exposure even prior to your testing positive within those first 3 days. And so but I think the key to it, as far as who should get it and why people should get it, really has to do with the fact of what is their risk to have going on to have severity of COVID-19. And so that's why for the FDA EUA labeling, you need to have the risk factors for having severe COVID-19, be that age, increased BMI, or comorbidities that would put you at risk for that, including pregnancy, et cetera. And so I think those, when you meet those criteria, then it's very, very important to try to access it. And we've done a very poor job globally, including in the US, to be able to get access to those individuals who need it to prevent them from going on to have severe COVID-19 infection. Does that answer the?
Sounds like a strong answer. Jose, would you like to follow up, or is it okay?
I'm just curious because your answer makes a lot of sense for me. But people, you're saying, it's not only access. People are getting very different answers as they connect their physicians. And also who should be doing this infusion. There are lots of small clinics doing infusion. How much should people trust them? So I think there's not a guideline on how people should behave on that. Should I go to my corner urgent care place that says they are doing infusion and do it? Or should I wait to go to a hospital? So I'm trying to figure out, as I read about it, the guidelines appears to be very confusing.
Yeah, okay, let's think about that overnight into tomorrow's discussion. In principle, the time budgeted for today is over. I don't see a signal related to my question. How about consequences and addressing the vaccination issue of small children? Maybe we can pick up that also tomorrow, but the Chancellor would like to have the floor. Marcelo.
My question is for all in reality, also to put in maybe in the final statement. I think that we have more interest to find vaccines and the solution of vaccines than to find therapies or medicines. We have many vaccines, but not many concretely medicines. I think that we need also to have a sort of protocol for the medicine, universal protocol for medicine, that this could be important to avoid that the people arrive to limit situations. So what is your idea about medicine? So,
okay, that sounds like a cross-cutting discussion, which we also need to address tomorrow. Very important question. Tomorrow, we will be in the hands of CJ Chen, who I expect will be more tough on timekeeping than I have been today. We will still have a chance for cross-cutting discussion, but I want to thank you all. CJ for kicking us off, Dr. Swaminathan, Abdul Karim Salim, Dr. Mizukami, Anvuli, Michael Sandi, for all your presentations. You have enlightened and enriched us a lot today with deep insights. And please engage in the debate of tomorrow's 8 presenters. And then in coming out with a strong, science-based, powerful statement, which needs all your input. Thank you, and good night to the East, good day to the West, and good afternoon here in Europe and Africa. Bye-bye.
Bye-bye. Thank you.
Bye. Thank you very much. Bye-bye. See you tomorrow.